So today what we're going to talk about is we're going to explain the role of environmental contamination in the transmission of healthcare associated infections. We're going to discuss the latest research on environmental hygiene in the operating room, discuss the perioperative nurse's role and responsibility in environmental hygiene, list the monitoring methods available to objectively evaluate environmental hygiene in the OR, new technologies in environmental hygiene, and then finally discuss results of a pilot program to improve environmental hygiene in the OR. So this is just a list, kind of shows you the impact of surgical site infections. Roughly 300,000 annually, 17% of all HIIs, second only to UTIs. It represents 2 to 5% of patients undergoing inpatient surgery. It extends the length of stay from 7 to 10 days and makes readmission more likely. It can lead to long-term disabilities, puts the patient at a 2 to 11 times higher risk of death. 3% die from their SSI, and 75% of deaths amongst patients with SSIs are directly attributed to that SSI. And from a cost standpoint, it can run anywhere from $3,000 to $29,000 roughly per SSI, up to $10 billion annually. So this slide talks about pathogens and how long they can live on surface. And as you can see, with C. difficile, it could be greater than 5 months, VRE 4 months, norovirus 3 weeks. So they can last a long time on surfaces. Patients with, this is a cycle of environmental contamination. Patients with pathogens contaminate the environmental surfaces near them. These germs become a source from which healthcare workers contaminate their hands or gloves, and then finally contaminated environmental surfaces can contribute to the spread of HAIs. Okay, latest research. Okay, this was a study done in 2012, and what it did, it measured what we call high-touch objects. We looked at both hospitals as well as ambulances, doctors' clinics, dialysis centers, and such. And what we found was this 32% of high-touch objects were being cleaned, which is obviously very low. And we looked at both daily cleanings as well as terminal cleanings. And one would think that, okay, well, if we spend more time in the OR after the case is over cleaning, it's going to lead to better outcomes. What this graph shows you that isn't necessarily the case. You could have some, a room turnover done in a little over 10 minutes with up to 70% or more of the high-touch objects being cleaned. And conversely, you can go over an hour where you're looking at just low 20s. So there's no correlation between the two. So this was a recent OR study, and what it looked at was decreasing operating room pathogen contamination through improved cleaning practices. And what they used was, it was a fluorescent marker called a DASO marker, and what they did was they marked the high-touch objects in the OR. And through improved cleaning and education, what you can see is their scores increased, and the recovery of gram-negative bacilli from the environment decreased accordingly. So it shows a correlation with improved cleaning and a decrease in the pathogens present. Acquisition of pathogens is decreased with improved cleaning. This is according to Shea. ICU rooms previously occupied by a MRSA or VRE infected patient increased up to 40% the risk for the next patient to acquire either pathogen. So the study suggests environmental contamination can play a significant role in transmission. Again, this was another study done in 10 ICUs, and you can see the pre-intervention, you had about 44% of the thoroughness of cleaning, and the contamination was roughly the same. But after post-intervention, and that included targeted feedback, use of the markers, increased education, which is key. You can see that the thoroughness of cleaning improved while the acquisition of pathogens was lowered. So what we need to do is cleaning breaks the chain of infection. Cleaning and disinfecting environmental surfaces in healthcare facilities is fundamental in reducing the potential contribution of those surfaces to the incidence of healthcare associated infections. So the industry is changing. AON has updated its guidelines to include objective monitoring and high-touch object cleaning. The industry is moving towards more evidence-based decision-making, and obviously, I'm sure you guys know the hospital they're moving towards more value-based purchasing, and readmissions are being affected by it as well. So these are approaches to programmatic environmental cleaning monitoring. The conventional program, which most hospitals are currently using right now, it's a subjective visual assessment. Basically, you're looking at the surface and you're saying, yeah, I think it looks clean. It's really oriented on deficiency, so it's only talked about when there are problems with the cleaning. The monitoring is done on an episodic evaluation, so it isn't continuously done. Again, it focuses on problem detection feedback, and then there's an open definition of corrective interventions. With an enhanced program, what we call it's an objective assessment. Either the object is clean or it isn't, and we'll get into that a little bit later. It's performance oriented. It's an ongoing monitoring. It provides objective performance feedback, and then it's goal oriented structured process improvement model. The CDC has updated its toolkit, recommendations for optimizing high-touch surface cleaning. It does focus on high-touch objects, and I've mentioned that a few times already. What we consider a high-touch object would be like things that are typically touched during a case. It could be the table railing, the OR controls, the light handle, the anesthesia card, just things that are typically touched during a case. So again, they recommend objective cleaning of the thoroughness of high-touch objects, continuous feedback that drives focused training for the ES staff, and then reports documenting progress, which can be shared with leadership or Joint Commission surveyors. Why is between case and terminal cleaning important? According to AORN, every surgical patient should be provided a safe, clean environment, and then the safe, clean environment should be reestablished after each surgical procedure. Operating room cleanliness can help decrease the risk of surgical site infections by providing an environment that minimizes the risk of wound contamination. Has shown the before and after. Microorganisms in the environment may cause infections. Environmental cleaning plays an important role in minimizing the transmission of healthcare-associated infections. Potentially any patient may be infected with bloodborne or other pathogens, and therefore all surgical procedures should be considered potentially infectious. Careful and consistent application of recommended cleaning practices is essential for optimizing safe care in the OR. You and what you do matter. It is between case cleaning. It is a team effort, typically performed by perioperative personnel, nurses, surgical techs, patient care assistants, OR aides, environmental services technicians. Communication is important. Understand your role and your responsibilities, and the perioperative RN has overall responsibility for verifying a clean surgical environment. Any questions so far regarding any of this? Okay, monitoring environmental cleaning. This was this slide talks about a comparison between different ways of monitoring. You have a culture, the fluorescent marker, which I mentioned earlier, as well as ATP, which is a swab that's used, typically more used in commercial food service settings and food processing. But if you look at the graph there, you can see a correlation between using a culture and the fluorescent marker, and there really isn't much of a correlation between ATP with either the culture or the fluorescent marker. So basically, if you can't do a culture, which is time consuming and costly, use of the fluorescent marker is a very good alternative. C. difficile is prevalent in the environment, and spores are the most difficult to remove. The spore form of C. difficile is metabolically dormant. It does not have ATP, and that's what ATP, the swabs do. It picks up proteins. C. difficile is not detected by ATP technology, and the removal of the fluorescent marker correlated well with the removal of bacteria or C. difficile spores. I don't know if you guys remember, I was here probably about a month ago or so, and I spent the day checking some OR rooms out to see how well they were being cleaned. What I used was what we call the Dazo marker. It's a fluorescent gel that I touched the high-touch objects with. You really can't see it to the naked eye, but if you turn the lights off, put a black light on it, it comes up very prominently. So that's what that marker I'm referring to. All right, new tools and processes. Microfiber products, you guys are using them right now. Increased productivity, better chemistry absorption and release onto surfaces, superior cleaning performance, large surface area, it cleans all types of surfaces, better microbial removal compared with cotton rayon blends, and it's very key that it's also lint-free. Microfiber is also sustainable. Since it's so absorbent, it can help reduce chemical usage because the chemical will stay. You'll have more chemical on your on the cloth itself. It helps conserve water. It holds 5 to 7 times its weight in solution, and it helps reduce disposal weights by weight. Okay, cleaning carts. This is an example. We have a cleaning cart as part of our Ecolab operating room program. I know you guys are using the cleaning cart right now. It's really a similar setup. Basically, it provides everything you're going to need to clean that room, from your chemistry to the microfiber cloths to the microfiber mops. It can also hold turnover kits. So once you're done cleaning, you'll have a turnover kit ready to put on for the next case. And one of the things about the basin that holds the microfiber cloths and the mops, there's actually a chart that shows based on how many cases you have predicted for the day where that cart's going to be used, and how many mops that you're going to use or cloths. It will tell you approximately how much chemistry to use. So you're not just filling the bucket up and throwing half of it out at the end of the day. We have there are sweep soaps available. This is actually a squeegee, and so I know when I was watching the turnover process, I think you guys are using a straw broom or a hand broom for getting the sutures and things off the floor. AORN does not recommend that. They really want to recommend something like a squeegee, anything that isn't going to potentially put microorganisms back in the ear when you're using the sweeping motion. Okay, the objective monitoring. The Dazo gel and data collection provided an objective way to measure the thoroughness of cleaning, and immediate feedback provided showing results of the cleanliness of the high-touch object. We have a cleaning program. It's part of our operating room program. Basically, there will be somebody that will be marking the rooms to see how well the high-touch objects are being cleaned. After the room's cleaned, they'll come back and check to see if that mark's been removed or not. If it's been removed, then it's considered a pass. If it's looks like it's been gone over but not completely removed, or if it hasn't been touched at all, then it's considered a fail. But what the surveyor does, or the auditor, they'll actually mark the results down on an iPad, and that information can be shared with OR leadership. It can be shared with hospital administration, your insurance companies. Joint Commission comes in. These are great reports to have to show, hey, this is what we're doing to monitor how well the ORs are being cleaned. It does give you a readout, and you can sort the reports accordingly. You can do it by shift. You can do it by room, whatever way you want to sort those reports out. But it's a really good way of keeping all that data available. So when people want to know, hey, how well are the ORs being cleaned, you can show them. All right, best practices and pilot studies on monitoring. This, again, I refer to the Ecolab operating room program. There's 4 components: service, training, information, and technology. For customers, the outcomes are improved cleaning results, reduced operating room turnover time, as well as improved operational efficiencies. And AORN has recognized this program since 2013, and it does comply with AORN guidelines. This was a poster that was presented at 2012 AORN Congress, and the graph on the left shows you the high-touch objects I was referring to earlier in the presentation. You have anesthesia card, you have back table, light surface, the handle, switch, the controls, the OR door handle and such. And as you can see, the baseline, which is basically what I did last month, you can see the scores on the left there. But then after the program was implemented and the training and education was given, you can see how well the scores improved. And that improved for both between case cleaning as well as terminal cleaning. Okay, this is actually a study that was done in Crestwood Medical Center in Huntsville. 19 ORs, real similar to the size of your hospital, 12,500 procedures a year. It was a 6-month program, and the focus was improved cleaning and disinfection while decreasing turnover time. And so on the first slide that I marked or circled there, that was the turnover times before implementation, and then the ones in the green box are the times after the implementation was put into place. Open it up there a little bit more. You can see how the turnover times went down. And then the second one is having to do with the high-touch objects. You can see that as soon as the education and training started, the cleaning scores for both between case and terminal cases rose quickly. And the key is that not only did they rise quickly, but they stayed high over a period of time. Another study that we did, hospital with 15,000 annual surgeries, we were able to shave 4.5 minutes off their turnover time. And then as you can see, as far as the high-touch objects, baseline was really low at around 12%. Week 1, it started to improve, but after week 1 and moving forward, you can see that their high-touch object cleaning scores significantly improved. And then finally, at another hospital, we were able to help them save a little over 3 minutes per procedure. And again, their baseline scores were relatively low, and then the program was implemented. Then you can see how well their cleaning scores were after the training and education. So you and what you do matter. Reducing healthcare-associated infection is the responsibility of everyone in the community. Thorough cleaning and disinfection of surgical environment is critical in preventing HAIs, and you do make a difference in preventing HAIs. So in review, we discussed the role of environmental contamination in the prevention of healthcare-associated infections. We discussed the latest research in environmental hygiene in the operating room. We just went through what your responsibilities are in environmental hygiene. We talked about different monitoring methods available. We described new technologies in environmental hygiene. And finally, we discussed the results of pilot programs to improve environmental hygiene in the operating room. Is there any questions from anybody? Yes?
So what was the results of when you ran a few weeks ago and did the?
Very similar to what I showed on the with the slides. I monitored, I think I looked at 5 or 6 between case cleanings, and I did, we call them audits basically, and I conducted 3 terminal clean audits.
Right.
And the scores were real similar to what we typically find and what was shown in the slides. I think was low to mid-20s was the overall average as far as high-touch objects being cleaned. There were some things that were being cleaned well, but there were many items that were not even being touched. So, and that's the whole thing. What we try to do is, is get everybody on the same page. Why it's important to clean, and what's important is we show how to clean. It's not just swipe and go. You need to put a little bit of pressure on the surfaces when you're cleaning in order to get the contamination up. Any other questions?
Is the program that you're promoting keeping it wet or is that still a long period of time? I know that's one of our biggest concern problem. We'll lift up a mattress 3 days later. A room that hadn't been used and is still wet underneath there, or
yeah,
it's not the necessarily the technique or what we're doing, it's just,
Yeah, one of the things I noticed was when I was, because I did the audits, but I was also kind of observing the turnover process as well. And, the cleaners that you use, they have dwell times based upon,
Right.
manufacturer specs. So obviously you want to keep it wet, but wet and soaking wet are two different things. And one of the slides I showed earlier had to do with using the right amount of chemistry. The cloths that can be used with this program hold the chemistry in place, but it doesn't necessarily have to be dripping off of it in order to clean. So we can show, and we typically can use just 2 to 3 cloths per OR to clean the entire OR and get the results that we're looking for.
Are we implementing this?
Well, I know it's being looked at right now, and hopefully, I think there might be some answer next week or maybe after the first of the year. But I presented the results of my findings to Kelly and Molly a couple weeks ago, and I think right now it's being, I guess, your director of medical is looking at it right now. So. But it isn't much different. You guys are using the disposable turnover kits. Really, the biggest difference would be implementing the training and education that I would provide. We also bring in a subject matter expert, someone that has been doing this for years. We'll actually bring in up to 10 people or so to spend a week or so at the hospital working with everybody, morning, afternoon, weekends, terminal cleans, between case cleanings, just so everybody's on the same page. Everybody knows, their role. If they walk into an OR room and it's already in the process of being cleaned, they can look and see where that person is at and know exactly where they need to go to start cleaning, just based on kind of where they're at in the process.
so you showed the pre, and then you showed post as far as the high touch objects and everything else.
Mhm.
But what I didn't see was like a third column that showed, okay, this hospital had an infection rate in their OR of 10%, and
Mhm.
it went down to 5%, or
Yeah, and the thing is, we can't conclusively say that that's going to happen, okay? But we feel that there is a correlation between improved high-touch object cleaning and a reduction in SSIs.
but you haven't seen that in your results, or you're not.
We can't
Tracking it.
we can't say that. That's what I'm trying to get. We have seen that. In fact, what the study from there was a study done in Allegheny General in Pennsylvania. And similar results, low scores to start off with, but after we implemented the program and provided the training and education, their scores improved dramatically. The OR manager from that hospital was transferred to Missouri Baptist in St. Louis, and I was there doing some work, something else. She saw me and saw my Ecolab, scrubs on. She pulled me into her office and said, "We need this program here." So she knows firsthand how it made an impact at the hospital.
Just curious.
Well, thank you very much. I appreciate your time.